Good morning, everyone, and welcome to Signals and Symptoms podcast. Today, I'm very excited. My friend Saira Huck is here. She works for Pfizer, leads health informatics, and very interested in policy and governance. And we're going to talk to her about AI and how larger companies, especially pharma companies, are utilizing and integrating in their workflow. She will introduce herself much better than I can, but I just want to quickly go with some of the weekly updates that we go through. This is an interesting article. Harvey, you would be interested to see that the Telas is actually going to come at 17,000 tokens per second. Insane. So we were talking about Grok and Cerebrus, and we were talking about last time, Edward, me and you were talking about demonetization and democratization of intelligence. And this is not going to be demonetization. It's going to bring bottom prices. And we're going to make intelligence basically, one GPU away. We have been looking at, me and Harvey have been discussing about OpenClaw and personal AI agents, etc. And the file system is the new database. And again, I don't like to show off some of this stuff, but let me just show you that I have been using Claude Code with Obsidian to actually do massive amount of productivity. And it is becoming honestly a little insane that 40 of my human employees are unable to keep up because now I have 20 AI employees. So again, things is massively changing the way that we do functions as well. This is again explainable, which is very important. Again, Saira is going to talk about it. By the way, just as a side note, my actual sister name is Saira too. So she's also my sister from another mother. So cancer integrated radiology, clinical picture, direct visualization. This is a very important read, especially if you want to look at explainable AI, especially in the multimodal format. Very well written. I would love to, you should add this. Too many beds tackling the waste epidemic in digital medicine. You have talked about Edward, how insane it is. And we have given you example that billions of dollars are being lost. And this article basically encapsulates it. Harvey, I'm going to send it to you, and you need to add that in your governance pitch deck. Cancer LLM, a large language model in cancer domain. So this is Saira. I wanted to bring this up for you, for your attention, that they actually have a data availability too. And the idea behind it is that it's only 2.2, they use 2.7 clinical nodes and 500 pathologies across 17 types. And we demonstrate cancer can potentially provide an effective and robust solution to advanced clinical research and practice in the cancer domain. We actually were looking into this, but we are more concentrating on the imaging side. And LLM is going to be insane in terms of when you can pull this together. So dynamic prediction of time of event outcomes. And this is really what those who are interested in actually the nitty-gritty of it. Time to event prediction is very important. So for example, if a patient is here with risk factors and then there's a stroke, when you are able to create machine learning and statistical procedures in an ensemble format, this is an amazing way to actually go ahead and do this. Again, it's a little more technical, but I just wanted to let you know that we are using this technique, which is, by the way, machine learning. This is not LLM or AI or generative AI. This is old school machine learning. We still use it, by the way, a lot. So, by the way, all your recommendations on YouTube and Instagram are coming from machine learning, not generative AI. This is, again, SAM 3D Body. Fantastic application of this. Learned a lot from this article. Towards steering and monitoring AI models. Again, coming back to Saira, she's going to talk about this more than I can actually intelligently, with, of course, Harvey being on the helm of it. So building a pro worker artificial intelligence, this is a must read. Like if you go through this, if you don't go through this, it is wrong. This literally tells you building a pro worker. And that's what, I mean, oh man. Okay. By the way, this is going to be the Harvey structure. Let me find that pro worker, stuff. But in short, the gist of the article is that you have two options now: augmentation or obsolescence. So either you become a pro worker with artificial intelligence, or you basically are going into obsolescence. Must read, very important for anyone who's thinking of, and all the kids, by the way, that if you're starting a new career, there were two skills that we used to check in SATs, right? One was English, the other one was math. English was language, the math was reasoning. And now you have to third tooling, which is basically using AI. I think SATs need to include that as part and parcel of their system. I don't know what you guys think about it. Again, dosing errors. This is so important when Sarah is designing clinical trials. How do we dose it properly? Again, super research, be able to do what we call both. Again, technical difficulties with my mouse. We have always been doing what we call deep research, or we want to do wide research. The other ways to do it is what we call super research, with both deep and wide research. And this is basically changing the game of how we are doing research in general. Now, I'm gonna, let Sarah introduce herself. It is her call if she's gonna talk about the AI revolution in drug discovery, or she wanna talk about AI-driven drug evolution from molecular design to personalized care, or she wants to talk about the convergence of ecosystem, basically how to put drug development in real world, essentially using guidance and everything, especially when we consider that FDA is now using real world evidence. So I'm gonna stop. Again, thank you so much, Sarah, for joining. If you can introduce yourself to the audience so that I'm not mucking up some things.
Well, thank you for having me. It's a pleasure to be here. As you said, my name is Syra Hawk, and I am a health informaticist by training. I will go through a little bit of my background just so people can understand, because I think that your background and how you're trained and the experiences that one has influences how they view problems, which is true really for any solution, but particularly with AI, because a lot of things rely on parameters, data selection, etc. So I'll start with my journey a little bit. After undergrad, I went to Michigan. I did my master's in Health Services Administration at the School of Public Health in the Department of Health Management and Policy. And so, really, from the beginning of my career, I've had a focus on policy and its application in real world. After that, I worked in management consulting for a few years when I went around the country implementing different types of implementations for information systems. And that was before we had a whole host of big EHRs. So we did things like design and develop custom billing systems, which doesn't really happen now, or implementing Meditech wide scale or things like that, which was
So you
really
are the
great.
reason that I hate medical environment now. Just
Well, you
kidding.
know what's funny is I feel like at the end, there's so many compromises that are made that everyone is mildly dissatisfied. So that probably is true for a lot of things in life, not just health information systems. But there's a whole host of considerations, and I think you don't truly appreciate it until you're leading something like that, because there's considerations across all the stakeholders. There's certainly regulatory, payment, all the kinds of things that all have to be considered. After that, I went to an academic medical center, and I was the compliance officer for the IDN, the first one actually. And I really enjoyed building the compliance office. It was really fun to start something new and develop the systems and processes. But that's not where my heart is. I actually didn't enjoy being the compliance officer as much as building the office. I think you have to have a particular mindset, and compliance is so important, and you need to have it in all aspects. But to be the compliance officer takes a particular mindset, I think. So then after that, I did my PhD at Syracuse in information science and technology, which, and I focused on health informatics given my background. I went to RTI, which is a research institute after that, and I started as a health IT research scientist. And when I left 11 years later, I led the data interoperability and clinical informatics program. I then moved to Pfizer, and I've been there almost 5 years as a clinical informaticist, and now I lead the Advanced Medical Solutions team, which involves both clinical informatics and practical research. And so throughout all of these experiences, they are different in a lot of ways, working in a hospital, as an administrator, management consulting, different types of research, and now. However, at the thread and at the core is using technology to improve outcomes. So, regardless of the setting, regardless of the different way, that's been the common thread throughout my career. And so I wanted to talk through my journey because a lot of people listening might be
Yeah.
coming from different types of backgrounds and not really see how their own educational background or employment experiences can lead
Yeah.
to different types of careers. So I thought it was important to share that for people who might be listening.
No, love it. I mean, it's interesting. The background of this various journey is always clearly, we always talk about it. Ed actually talks about it more than I do because we have two physicians, and he brings in this board sort of situation that, when you are looking at innovation, it's about cross pollination of skills.
Hmm.
So you need to be somewhere between, talking about with one domain expertise to technical or whatever that case may be. And the idea is that innovation happens when you have this interesting sort of journey, especially when you're looking at due diligence for even startups. So, what is your current role at Pfizer, and how are you sort of looking at healthcare AI in general?
Hmm. Yeah, that's a good question. So I work in U.S. Medical Affairs. So that means that's the department that I work in general. And I lead
Mhm,
a group called Advanced Medical Solutions, which is
mhm,
comprised of clinical informatics and applied research. In terms of the applied research, we're really looking at solving real world problems in identification of patients, management according to guidelines, and quality improvement initiatives. And so those may or may not involve informatics. However, informatics is everywhere. So usually there's some component, even if it's not the primary focus of the study. I also have a group of clinical informaticists who are trained, and we work across the spectrum, really, looking at things like EHRs to help identify patients for clinical trials, EHR innovation once people are in the system, real world data and evidence and different analytical techniques, and then evaluation and continuous improvement. So there's really a whole host of team things that the team does. Now, one thing that I would like to kind of point out is that AI is, I guess, the latest in a series of technical innovations. Throughout my career, I have observed, I guess, like a little hype cycle of different aspects. There was a hype cycle for telehealth. There was a hype cycle back when the EHR first came out and became I guess, more widespread. And so with all of these things, the technologies are different. AI is different than, um, like a, coding like a mainframe, which is different than, all these things they do have some differences, but the underpinnings are the same. The underpinnings of what needs to happen to make something successful beyond the pilot is pretty much the same. And that's actually something that I really enjoy is taking something that we're studying as perhaps a pilot study or an initial feasibility study, research, that kind of thing. And then how do we take it broader? How do we scale? That's something that I really care a lot about because I feel like we spend so much time and it's really fun to bring innovations out and to think about them and think about how they work and start them. But then what can we take that will impact people more broadly? And so what can we take from an innovative pilot study at one institution and learn from that we can scale more broadly? And so that's something that I really like to focus on. And now the focus is AI. My whole team is working on it. I'm working on it. But um, I think I just want us all to really kind of take a step back and think about, okay, well, what now what? What can we actually do that's practical? And I like the innovation, obviously, as you can tell from my career. And I also really enjoy thinking about what do we do to take those things and bring innovation to more people. And so it might not be that everyone gets bleeding edge right away, but by taking things broader, even one step at a time, we can move towards better patient outcomes, which is really at the end of the day why we're all doing this.
Love it. Love it.
Go ahead, Harvey. Floor is yours. Or Ed, if you have any
Yeah.
questions.
No, so many things I want to say. Number one, thanks for coming. It was a pleasure meeting you over the summer last year. And immediately when I met you, we were talking, I could see you weren't just superficial. You were looking at where can we go with this? How can we help humanity? So I applaud you for your efforts. For me, I've taken the torch of saying, you know what, I'm going to do some TED Talks on the same thing, because if we don't know what we don't know, how do we know what to fix, right? And if we don't know these tools exist, then how do we implement them? And so my goal has always been sharing. So love that you're on the podcast. I really want to see what you have to say on the drug development side, because obviously I'm into that, because I really think that's the next frontier for us to get to personalized medicine using AI and these discoveries and lowering the cost. So that was just my comments, just in general.
Yeah, this is a super fascinating discussion. I've written down several questions for you that I think might resonate with the audience. And you sort of touched on the edges of some of these, but how, this is your profession, and so you have a little bit extra pressure on you. How do you keep up? Like how I keep up, one way is just participating in this podcast, learning from people like you. And then when Junaid goes through his first 5 minutes every time, I'm like taking copious notes. Like, oh my gosh, there's so much going on, and I try to keep up as well. And I know it's a struggle for everyone. So I'm just curious if you have any personal like hacks or things that you do, or does it just come natural because you're in it?
Oh, I don't know if anything comes naturally to anyone in terms of all this kind of thing. So even when people have natural ability or talent, you need to have the work to back it up.
Yeah.
But in terms of how I keep up, I agree. I mean, the pace has just been astronomical. I think in tech, the pace is always fast, but over the last 5 years, I have observed that the pace of innovation, the types of innovation, the stakeholders involved, that is all really accelerated. I am a fellow of the American Medical Informatics Association, and I've been a member since I was a doctoral student, so 20-ish years. And I will say that I use them a lot to keep up, because there's a whole host of things like conferences. I'm on the industry council. We get newsletters every day. So there's things like that to help keep up with the forefront of what's happening in research. I've also been pretty involved in policy, and so I subscribe to a number of governmental type newsletters to keep track of what's happening on the regulatory side, which is a little bit different because the pace of technical innovation outpaces the pace of regulations, policies, organizational governance, etc., which is to be expected. But at the same time, it's important to keep up with both arms, because they all are interconnected, so it's important to catch up there. And then, of course, there's a whole host of technical things to keep up with. One reason that AI is even possible is because of technological advancements. So it's possible to analyze more data. It's possible to integrate across more data sources. The computing power exists that didn't exist before. I mean, if you think about it, we have computing power in our pocket that in the 60s would maybe take up a whole entire room, and be so, all these things had to be in place. And so it's important to keep track on all different types of fronts. And yes, it's a lot, but if we don't keep up, then you'll get left behind. And so I really encourage people to keep up with what's happening, but also in different arenas. So technical, the environment in terms of policy, and then health in particular, because without looking at all three of those, then it's really easy to miss something important.
Yeah. Yeah. And one other question along these lines, Junaid, I know you want to get into AI and drug discovery or those other cool charts. But just one other question, because I know that our audience has the same question. So talk about a little bit about career advice. So a lot of people look up to you. You're a well-accomplished person, professional, and they want to be like you. They want to be in your role. Of course, they want. My little side comment is they want it to happen in 1 year as opposed to working the ladders that you work. But all that said, if you're a fairly new grad, maybe you're just 5 years into your career, what is maybe 1 or 2 words of advice that you would give someone who aspires to be in a role such as yours?
Yeah, it's a good question, because I think that career development and even the way the career landscape now is very different than it was when I first started my career. And I think that's important to note. The environment is different, the context is different. However, just like the underpinnings of technological implementation are the same, so too are a few underpinnings for careers and thinking about it. One thing I'll say that I'll start with is to be open to all different types of opportunities. When I first did my master's, I wasn't really thinking about technology that much. I liked technology. I thought it was interesting. I did some things with it, but it really wasn't on my radar. I was really thinking about myself as more of a policy person. But as I came in and did my coursework, and then as I did management consulting, where I started the strategy practice, actually, I really enjoyed it because came to see that technology, systems, processes, and strategy are really all linked together. And I actually came to enjoy aspects that I didn't even know existed. So one thing I'll say is to really be open to different experiences. And that might mean experiences such as you're asked to take on a new project, or you're asked to maybe you think about this job you might be applying for, or things like that, really to be open-minded. And not to, another thing I would say is I've observed a lot of people who ask me questions will often cut themselves off before they apply for something or before they put
Mm,
themselves into consideration. And I always think, you don't have to cut yourself out. Let them do it if they're going to cut you out,
Yeah.
or put your head in the ring and think, because everyone has a whole host of different experiences when you're at work. Once you get a role, I've observed that as well, where sometimes people will say, oh, well, it's always been done that way, or we're not going to get approval for that. And it's like, well, why? I think it's important for us to really think about what are things that we have to do for a variety of reasons. That could be regulatory, for payment, whatever the case might be. There are certain things that are non-negotiable, right? But then there's a lot of area in which you can do things and can
Yeah.
make innovation. And I say this all the time, if you do what you always did, then you're going to get what you always got. And then you're not, and the world isn't the same. So we need to move. So I say that all the time. And then the
Yeah.
last thing I'll say is if you're going to do something, commit. I say this all the time too. If you're going to ring the bell, ring it. Don't just like half-heartedly ring it. Don't, don't, kind of go half in. That's
Yeah.
right. That's right. If you're going to go in and go in full force, put your best effort in
Yeah.
and don't go in half-heartedly, because that will influence what comes out. It might not be that everything is successful. The very tenets of innovation mean that they won't all be successful,
Yeah.
that otherwise you're not being that innovative. If it all is, if it's 100% successful, if everything goes 100% according to plan, you haven't pushed the envelope enough.
Yeah.
So we need to be comfortable with that. And then also to think about, what can we learn from things that didn't go as planned? And what can we learn from things that, even during the process, if there's a hurdle or a roadblock, to me, that's an opportunity. And it's a mindset shift. I didn't think like that in my 20s. In my 20s, I wasn't like, yes, I'm going to embrace failure. But as you get older and as more seasoned in your career, have more experiences, it's really important to think through what are acceptable risk tolerances, and then
Yeah.
what can we learn from those. So those are the things that I think are really important for people to consider as they think about their own career development.
Yeah. Thank you so much. It was like a commencement speech. It was so good.
it was.
I mean that is a great compliment. That was so good and spot on. So thank you. Junaid, I'm sorry I took it a little bit different.
No, don't worry about it. So two things so first let Harvey add some of his experience.
Yeah, I gotta jump in. I'm sorry again, Janae, for not jumping into the next part. I gotta unpack this because I really want to say a couple of things that people didn't realize that she just said. In the age of AI, and I'm gonna bring this to AI, we're all scared that we're losing our jobs, and oh my gosh, AI is gonna replace me. But listen carefully to what she said. She put herself out there, and she hired people, and she wanted to be the people that wasn't common. Because if you think about it, to her point, if we're trying to do the same thing and we hire the same people that think like us, we're going to get the same answers that we were going to give out. But if we get someone different, i.e. your personality, your clinical gestalt, what makes you, your personality, that secret sauce of you, plus now we'll throw in the modern AI and you put it together, you're going to get some crazy good output. And so I really want everybody out there to really reflect on those statements, because it is true. And one other thing, when I used to run hospital systems for marketing, for other silos, I would hire people that did not have experience in those industries because I knew they had that secret sauce of their personality, and they could combine, and I can teach them X, Y, Z. But it was that combination that made them so unique. And then the last thing I want to say is, it's looking at it with children's eyes. If you can see something and you're naive to it, for example, I'm working for a space company. I'm coming in working with scientists, but I'm looking at it with different eyes. I'm able to come up with different solutions for the company that they wouldn't see. So anyway.
That's so true.
Amazing.
And one other thing I
Amazing.
wanted to amplify from what you just said is the way that you're trained, people's educational background, their perhaps work experiences influences how they think and how they view problems. And so going back to the team composition, it's really important to have people with different types of experiences for that reason. I'm an informaticist. My PhD is in information science and technology. I see things as information problems. I have a physician informaticist on my team, pharmacy informaticist. They view things differently because of their training. Their tolerances are different. The things that they pick up are different. If I hired a bunch of informaticists like me, we would all look at the same aspects of a problem. But one piece of that is also being comfortable with having discussions where we don't all agree on what the core problem is. But that's because of our experiences and background, and it's important to shape that and really embrace it so that you have a better solution and that you have better answers to the things that you're trying to address.
Very well said. Reminder, it's very hard for females to jump on top. And then secondly, it is harder for, people of color. So amazing work. I just want to make sure that people understand that it is coming from someone who has lived the issue. I have so much to say about it, but I want to ask you a few things. So this is going to be a rapid fire. Now we understand. So the whole point of this podcast is signals. So remove the noise, which is hype, and concentrate on the signal, which is actually this. And we talk about this, that overcoming the AI-based discovery of drugs is going to actually decrease from 1 to 10, 10 being definitely in the next 3 years, and 1 being total bullshit. How would you rate that this is actually going to happen? Because I'm just going to be honest, is there really a drug out there by AI? I mean, I know one of them, but what I'm saying is that, what do you feel in the industry between from 1 to 10? Do you think this is bullshit or?
I don't think that things are so black and white in that sense, because there's aspects that are happening right now. And, will there be 100% AI developed drug without people involved? That doesn't seem likely. Will AI be used to influence various aspects? Yeah, that's happening as we speak, somewhere probably right now. And so I think what we could really think about, and one thing that I really am excited about, is how can we use AI to really make things more relevant for particular populations and subpopulations. Traditionally, there's been someone like a one kind of patient profile that's common for many clinical trials. And the further you deviate from that in terms of race, age, sex, other types of comorbidities, then the less likely it is that results from trials will be relevant for you. Now, with AI, there is the potential to analyze more types of data, to delve into subpopulations that perhaps aren't available in structured data, and to really delve into how do different types of disease progression, certainly medications and comorbidities, impact different types of subpopulations. And now, from at the health system level, more people are capturing data around different types of subpopulations. So when you marry that together, we lead to what Harvey was talking about earlier, which is moving us more towards precision medicine. And so I don't know that we're at the point of precision medicine for Syra Hawk, but perhaps we're getting closer to the point for precision medicine of Syra Hawk of a certain age, of a certain ethnic background, with these kinds of health considerations. And so that's what I'm really excited about, because with the increased computing power and also the increased velocity, veracity, and amount of data, we really have more things that we're able to do with the computing power that we have. So that's one thing that I don't know if I would take me to a 10. It's hard for me to get there, but it's definitely going to get me further along than perhaps I was when this first started coming on the scene.
So that's one of the basically the holy grail, and I don't know who's going to get there first. The wet lab is basically what's happening at, I don't know, Pfizer, who's just published that they're going to do drug discovery from just to 30 days, save 16,000 research hours. Genentech is saying that it's actually going to degrade a molecule by 25% faster. And then, of course, me and other stuff like in Cleveland Clinic, we can deploy it. So the core holy grail is that the wet lab, which is inside Pfizer or any other company, we don't know inside Sarah Huck's lab. I don't know where she. And then the dry lab is essentially me or a community of similar me. So in your opinion, we are getting closer from what we used to say, like, okay, statin for everyone, to a specific statin for this particular population. And then eventually you're going to say that Junaid needs to build this particular statin period, and we are probably going to customize it for him. So in this, exactly what we want to say is that the wet lab, we're coming close to the dry lab as soon as possible. Now, here's the issue where, I mean, we can talk about so much of it, and that's where, these guys always push me. Let me find it. FDA regulation and it has actually improved, by the way. I can't find that slide that I made recently. But what do you think that from a global regulatory alignment on AI, where are we at? And what do you think, how would you govern, let's say, a biosimilar or for me, or a statin for me? And, I mean, Harvey is a health horse, so he doesn't need any meds. So Ed actually already had a Widowmaker, and now he's actually taking care of it. I wish I was, but anyways, long story short, how do you actually like deploy it? I have made many products. I've been selling, fantastic, beautiful. But believe it or not, now I feel like making a product was the easier part than implementing.
That's right.
And then the regulation part was the hardest. So when you see this future, how do you see it? Again, I understand it's going to, take so many things, and Europe is going to have some, and Saudi is going to have some, but FDA is going to have different. But what do you think is how people are thinking that how it is going to look in the future? Sorry for the long question. But.
That's a great question. So a couple of things. One thing I was thinking about as you asked your question is, yes, there could be a specific statin design that is for you, for instance, but perhaps you have a different LDL target than Harvey or Ed or me. Perhaps the target that we're even aiming for is different based on our particular health and our particular background, our particular demographics. So even before we get to the medication, we have to think about, well, what are the goals for us and why? Typically or even lab reference values. There's one set of lab reference values typically, but why is there one set of lab reference values? Why do Ed and I have the same set of lab reference values? That doesn't really make sense for certain things, right? And so then right now we're relying on providers to keep up with their knowledge of what's happening in the literature, to understand, perhaps to look at, well, what is this patient cohort for this particular person, that kind of thing. And that's not, and use that to interpret results, and then use that to inform their prescription or whatever maybe their care decisions, I should say, because it may or may not be medication.
Just to give you a real world example, the CBC count and the normal values were set sometime in 1970s.
Yeah.
And at that point in time in US, it was generally, Scandinavian population descent. And then my mom always calls me, Beta, I actually have low, I'm anemic. I said, no, you're not. You're 5 foot. Coming from a darker skin, you're not anemic. This is normal for you. So it's insane. You're so right that we don't have normalized values per population. So sorry about that. Go ahead.
I'm sorry. I want to jump in one more time.
Yeah.
I love what you're saying, because it's like, oh my gosh. Okay, so I've been working on my own digital twin, and for this reason, what you just said is one of the things I'm using it for. I'll be open. I have a genetic disorder-ish that can increase my homocysteine levels. And so my normal range is not normal for the population. My normal range
Mm-hmm.
is lower. And as a result, I need to make sure I take certain B vitamins. And so
Mm-hmm.
as my digital twin is examining who Harvey Castro is, it's looking at my genetics, it's looking at my wearables, it's looking at my habits, it's putting all that together. And in this example, it's doing exactly that, saying, hey, Harvey, your labs actually, we just got them back. It looks normal, but for you, it's actually over here. And so
Mm-hmm.
I just wanted to highlight that, not for the product that I'm developing, but more for this problem that we're looking at. It's a bell curve, and we don't fit in a bell curve.
That's right. Yeah, and actually, going along those same lines, there's actually an NIH-funded cohort looking at cardiovascular disease in the South Asian population. And identification of the South Asian population is not typically available in structured data. And they had to make a whole separate cohort. However, cardiovascular disease and diabetes are disproportionately high in those populations. So, coming along to that same exact example, perhaps the recommendations would be different and the targets are different for those populations. There are certain anatomical things that are different. There are certain genetic predispositions, etc. So then, kind of going back to, Auntie Kalia saying that, hey, I'm anemic. And Janae's like, no, you're not. This isn't for you. But, how many people know that? How many people have a physician, son or son-in-law or daughter that they can call and ask those questions? And an unintended consequence of the 21st Century Cures Act was that, people have access to their results right away through patient portals, which for some people is great. For me, it's great. I don't want to wait. I don't want them filtered. I want to read it and then I'll figure it out. I'll go in if I need to, I will look things up. But is that great for everyone? And, is that great for someone who gets a result that might appear abnormal on a Friday afternoon because it comes real time, but then it's actually not abnormal for them? And then they have to wait till like Monday or Tuesday to find out that, oh no, actually it looks abnormal because of the reference values, but for you it's fine because of X, Y, and Z. They need that kind of interpretation. So like everything, there's positives and negatives. I'm not casting aspersions. The intent was great. The
Yeah.
intent was good, but then there's things that happen. And so, and going back to that funded study, a lot of people don't know about it for a variety of reasons because it's more in the research realm, and that's one reason I'm so passionate about taking things from pilot to practice. Because what's the point of having that cohort and that's just one example, but in general, what's the point of doing all that if we're not going to scale it? And going back to something Junaid said earlier, I completely agree that implementing is the hardest part. The tech and development and all that's the easy part. And I'm not saying it's easy because, obviously it's not, but that's the part that you can do more quickly when you have to get in organizational stakeholders. You have to worry about clinical, administrative, and technical workflows and the people who are responsible for them, governance, both at the organization and at the policy level. That's where it gets hard. That's where the
Yeah.
rubber meets the road. So, I feel like I could talk about this all day, but I'll pause and see if there's
No,
anything else that we should talk about.
this is amazing. I do want to say two things. I know there's a lot of people learning about AI in healthcare and this. So I just want to unpack something you said,
Yeah.
just from a basic point of view. We all have heard of biases and this algorithm doesn't represent this population. Well, here's a great example of what she just said. If our training data is only looking at certain population, it's going to only benefit those people. It may not apply to these other people. And so if we don't have the studies, then the AI is only going to know what it can see. So having studies like this, having that put into the training model to be able to push it out to now serve that community is so important. So I want you to keep that in mind when you're looking at products. The second thing that she said that I really want everybody to unpack is she said something key, and it's actually, I posted that this morning. It's about culture. If we all in this table love AI, understand it, use it, but my colleagues are like, no, Dr. Castro, I'm not using that thing. It scares me. It's not going to happen. So we need to, as a culture, understand. And my favorite thing I always say is look back at 2 years for everybody at this table. How did you use AI 2 years ago, 3 years ago, compared to today? You saw a shift. Why? Because you got educated. Second, the culture has changed. So anyway, Ed.
Yeah, I was writing the same. I was in the chat, writing the same thing that you were actually as you were typing. Um, it is funny, right? We're all into AI. We all love it. We understand the
Mhm.
power of it and what it can do, and save people's lives and all the great things. But at the end of the day, when it comes to actually implementing, it still comes down to people. And
Mhm.
yeah, it's all the things you said. And the other one I added was courageous leadership, because I know so many times like people are just afraid to make a decision, and I had to be the
Yeah.
one. I've got some scars. You get scars from it too, but that's what leadership is. If you don't have scars, you probably weren't a very good or aren't a very good leader. You got to be the
Mhm.
one, go out there and make things happen within your organization.
That is a pet peeve of mine, actually. And if my team is watching, they're probably laughing because I cannot stand when we perseverate over and over
Oh,
about the same topics and just kick the can down the road. I would rather gather the information we can, make a decision, and then move on. And then if it wasn't the great decision, then we learn from it. But that is everyone has a different probably other people find that to be frustrating, but for me, if we're going perseverating on the same few things for a long time, I can't. I did want to highlight one thing before, though, about the bias and representation of data. That's something that we really need to spend a little bit more time on as an industry and as thought leaders, researchers, as people in this space. So many models, even models that are implemented and widely used in clinical practice, are developed on local data sets. And what I mean by that is they're developed on a data set at one institution in one region. And the amount of times that those models are validated on a national data set, on a more representative data set, and then adjusted before going into practice, it's not as high as you think. If you look through what's in pretty much any EHR vendor, look through what's out there in practice, look through what people are using in wearables. Oftentimes, they're very local models. And so to go back to our points before about making sure that we address the entire population, which we all live here, we should all be addressed, we're all getting care, then we have to think about the data and we have to think about the provenance of the data. We have to think about who's in and who's out of data sets and why. And then going back to the policy that I cared about in the beginning, well, why aren't people in data sets? If people are not getting their care because they don't have access, if people are getting care in a free clinic and it's not documented or maybe it's documented in a different way, it's not part of the HIE, then all those people, that's a whole big group of people who are not going to be in data sets, which means that they will not be represented for a variety of reasons. I love using real world data because I love using things that are already there, and there's a whole host of reasons that it's good to use them. But every single data set, there's no data set in the world that's a perfect data set. There's no such thing as like a fully representative data set. That doesn't exist. But which is okay. I mean, it's not really okay because there should be, everyone should have access to healthcare. However, what I mean is that doesn't mean we don't do analytics. It doesn't mean we don't use them. But what it does mean is that we need to more clearly articulate the limitations of each data set. And we need to clearly articulate what we're doing to address it. There are analytic techniques that could be done. We can change around model parameters. There's a whole host of things that can be done. And I think that those should be part of what we do, part and parcel, when we're thinking about AI and implementing more broadly. And I know that some strides have been made. There's been some governance strides in the US and Europe, some of the things that Junaid alluded to. But those are still not widespread, I guess, best practices or kind of things that have to happen before implementation. It's kind of like testing with a general technical, testing is always what gets compressed. Every time if an implementation goes long, you're like, oh, we'll just shorten the testing. It'll be fine. Well, you're gonna test before or after. And I feel like it's the same kind of thing here. If you don't follow the best practices before, it's gonna come out somewhere. And so, and I think that's something that I guess I could talk about this all day too, but that's something I really think we need to pay more attention to as an industry and make that part of what do we see, almost like a flow sheet or a cover sheet for each model. What's in it? What's not in it? Who's in it? What testing has been done? Things like that. That way people really know what they're looking at right now models are in place, people are using them, AI
So
is in
yeah.
place. You don't know where it comes from. So
Mhm.
those are
Sarah,
things
by the
that we
way,
should
so
spend
many
time
things are
on.
changing with the agentic AI. So
Yeah.
just to let you know, the next batch of FDA approvals, the four we're going to go through, uh, exactly, just the status,
Mm-hmm.
not testing. Testing is done by humans and confirmation, but automatically just updating the status quickly made such a huge difference in efficiency. Because what happened was that the whole team actually had the visibility. Going back to the data silos and
Mm-hmm.
then this, just to let audiences know that FDA has actually published the data of synthetic mammographies of breast. That is actually one of the best data sets on mammography itself.
Mm-hmm.
What we have seen is that if you have enough data, in the sense like millions of images, we're not talking about small, and then you have the right way to do what we call synthetic data, we were able to actually augment our data with all, I'm telling you, all the edge cases. What do you mean by that? Is that I can have a 22-year-old Nigerian woman with mammography of a stage 4 cancer done because I have 200 million mammographies available with a lot of Nigerian and a lot of, etc. So I don't know what your thoughts are on that, but just again,
Mm-hmm.
FDA is now not officially 100% on paper agreed to it, but you can request it that, hey, I cannot find this
Mm-hmm.
data. It's a very minute edge case. Is it okay if I use synthetic data? And believe it or not, you will be surprised by the answer. But I just don't want to give away some of my stuff. But what I'm saying is that what you have the and Harvey, what are your thoughts on synthetic data? That's the right term, which people use. I don't like the word. I use the word augmented data. And the reason I
Mm.
use the word augmented data is because it comes from actually the basis. Harvey, first you go ahead with your digital twin and everything, and then I'm going to ask Saira that do you think it's ever going to be implemented in industry?
Wow, this is a big controversial area. I'm biased when I say it. I think synthetic data, doing it correctly and being a data scientist from that perspective, I see a lot of weight to that, and I think it's a good thing because again, my focus is the patient. How can I help this patient? And if I can get over the culture and create a new paradigm way of doing things and helping my patient, then I personally feel ethically it's a crime that I'm not using this technology if I see
Mm-hmm.
someone dying because I'm not using it, if per se. So I'm big on it.
I think like a
Saira, what
lot
do
of
you think?
things. Yeah, I think that there's a lot of promise. And I don't think it's really a matter of if it's going to be used, but the degree to which these data sources will be used and the degree to which people will use the digital twins they're there now, right? Like they're there. There's I do like your idea of augmented data versus synthetic data. I like that term. I'm going to start using it. I'll write a paper on it. And I like it though
Dude,
because
you should Harvey, I should follow your lead and trademark everything.
oh no, yeah, you better
Go
it's going to
ahead.
be a
I'm just
race
messing
then.
with you.
We should
Yeah.
trademark it together. That will be the outcome of today's podcast.
You're my sister, so you're fine. I'm just messing with
That's right.
you.
But I actually feel like that with a lot of different things, that it's not so much if, but how. So all and with kind of with a lot of the things that we've been talking about, it's almost how and to what degree, and those are the things that we need to really kind of consider, because I know that saying is overused, the devil is in the details, but especially here it really is, because people might say, well, I don't use AI, I don't like it. They're probably using AI and they don't know it. So there's a lot of things like that it's important for us to know and then really think about and consider so we can make a reasoned decision. And sometimes the decision will be not to take the recommendation. Sometimes the decision is just to use it. And that's fine. And it's also important to think about, well, what are the things that you really need someone to look at? And what are things that we're comfortable just kind of, letting training on a good data set and allowing the AI to move forward. And I think those are things that we really need to unpack and take a nuanced approach. And that's where going to, Junaid, kind of to your point earlier about the implementation part being hard. That's what's hard. It's hard to kind of balance all the competing priorities, stakeholders, considerations, and arrive at decisions and then
Of
implement
finding
them
an appointment with
practice.
Harvey because he's in the middle of a war zone. So,
Well,
so
wherever
it, I
he
mean, to
goes,
me,
that's what follows. And actually, wherever Harvey goes next, I guess that's where we'll see the next conflict.
Technology
what I'm saying is
disruptor.
that in
For his
implementation,
mother.
I think one of the biggest, bottlenecks has been that, okay, the contract is even signed, but I can't find a goddamn person to set up a meeting for 3 to 4 weeks. So, what I'm saying is that
Mhm.
that you're so right, that insane amount, because, everything is going to. Ed, you set up a point in the chat, which, by the way, I have to start paying attention to, is that there's a new medical school where all graduates have med degrees and engineering degrees. I did not knew that.
Yeah, I'm headed there next month. It's
Oh,
ASU,
cool.
Arizona State, and I'm meeting
Oh,
with the dean, and she's going to share the whole philosophy. So I just know the headline. It's a friend of mine that's the CIO there, and so I'm going to head out there and visit, do a tour. And yeah, one of the reasons I wanted to do that was it's the latest medical school and in the United States, and I thought that was brilliant. And I want to know the reason, and I suspect it's something that you said earlier. You said about the tooling, right? We got all the other stuff already, but now the tooling. And so I think it's to learn how to, think like an engineer and prompting and all that kind of stuff. So I'm there to learn. I'll report back for sure.
Oh, I can't wait to hear what you learned. That sounds really cool.
I would love to. And by the way, we should bring the chancellor on to this podcast.
Yeah. I did that with the other, I guess if ASU is the latest medical school, I could be wrong on this. It's not my area of expertise, but the one previous to that is Belmont, Thomas J. Frisch Jr., Belmont or School of Medicine or something in Nashville. And I was there a year ago with the dean, and they use a ton of AI as well, especially in their simulation lab and other areas. So that, this next generation of clinicians are much better trained, but I suspect not all medical schools are there yet. These are just two of the latest, the new ones. They had a greenfield opportunity. So pretty interesting.
Going back to the informatics part, a lot of departments of informatics, or many, are located in medical schools. Some are located in schools of public health. Some are, they're all in different places. And regardless, there probably does need to be a little bit more of a tie-in with education. And what I've observed is that some places have maybe a lecture or some have a class. I've not seen one that has an entire degree, which is pretty amazing, but we'll see more of it, right? Because it has to be there. People are going to be called on to be perhaps a physician champion or to review output, and they need to know what they're looking at and what the considerations are. I think it's great. I can't wait to hear what comes of it.
Yeah, it's great. The CEO of ASU, he has his own podcast, and it's in the back of a Waymo.
Oh, I love Waymo.
In the Waymo, and you just talk. It's very clever. They're very tech forward.
Interesting. You got to share the link with everybody now. I got to watch an episode. This sounds fun.
Yeah, awesome. I mean, I love that. So Harvey, you are official advisor to Ministry of Health of Singapore. And then here's my thing that I just told you about this, this data distribution issue. And then how would you advise the health ministry that Sarah Huck should come and fix your data problems?
Well, I think you're overstating what Sarah Huck can do.
No, but what I'm saying is that, like,
I'll identify problems all day long.
But do you understand what I'm trying to say? That they are actually in a unique position as compared to US, because US has privatized data. US, it's insane. I don't know if they have the CBC, from a 6'5" of a Polish woman as a standard or something else. So what I'm asking is that what do you see there? And we have 5 minutes, so I'm gonna and then you can go ahead. So
I'll keep it short. Basically, basically they're really lucky, and I got a little FOMO, I'm not gonna lie. They have a somewhat uniform population, and that helps with the data sets to some degree, because a lot of their studies, and to give you a real example, they have everyone's genetics, which for better or worse, depending on what side of the spectrum. But here's what they're doing that is special. They're leveraging their uniqueness, they're leveraging their genome, they're being proactive, and what I talk about is proactive medicine, and looking back and saying, you know what, this particular population will have a heart attack in their 20s. We should take a look at them in their 10s and their teens, and maybe start them on different medications or different programs so that they don't have a heart attack. And in my mind, I'm like, wow, you're leveraging AI, you're leveraging your population, you're able to do studies that we can't do in the United States. And another thing I'll just share real quick, I was seeing the software they have, and they're like, okay, let's look up all the diabetics. And then they did a quick search and for their patients, and they were like, okay, here are the worst diabetics for our population, and we can correlate that these individuals live so close to so many fast food restaurants, and we think there's a correlation there because their eating habits and their hemoglobin A1C. And I'm like, oh my God, I am so jealous. I want those tools for my patients here in the USA.
So again, coming back to symptoms, and because one of the things that we also talk about is entrepreneurship. Sarah, if you know any startups, feel free to introduce us. We'll bring that. So any other guests you recommend, we'll want to bring them to the podcast. By the way, before you stop recording, make sure that it uploads. Last question, and then we're going to just automatically close out of that. If you had a magic wand and a wish list to actually use personalized medicine in 1 year, what would that actionable item be?
Wow, I have so many things that I would like.
Just one.
One thing about courageous leadership is you're not afraid to ask. So I want a whole host of things. One is going back to our data conversation before. We have data on a whole host of conditions. We have data on different types of people, but it's all over the place. It's not all structured, and it's not representative, as we talked about before. So I know, it's a magic wand. So with magic, I would love to see an actual representative data set that's integrated across systems, settings, etc. And I think that would be amazing, because by fixing that problem, you fix a lot of what happens later with AI, because you don't have to think about, well, do I have this history data because this person was seen, in 3 different systems, and now I'm trying to figure out their medication history, and now I'm trying to, all those kinds of things. But if we could fix that, which I guess in Singapore they have, but maybe in the United States, that would be amazing. And that would really lead to a whole host of other things that we could look at in a more holistic way. And if we could include things that are health related, but not health data, for example, workouts, wellness, things like that. So those are things that very much relate to health, but aren't actually available in many EHRs, for example, or people may or may not ask about them, or, like patient generated data. We haven't even touched on wearables and all those kinds of things. So when I'm talking comprehensive, I mean comprehensive. That's what I would like to see.
Thank you so much for joining us, Saira. Thanks for my co-host as usual. There's an amazing paper from Google. Everyone wants to do the AI work. Nobody wants to do the data work. For high impact, which is health and military, data is so much more important than anything else. Grateful. Thank you. See you guys next week.
Thank you for having me.
Thank you for coming.